Hi, Dr. Momi here. In this video, I will talk to you today about a TLIF, or Transforaminal Lumbar Interbody Fusion. Before we get into that though, just a little disclaimer. What I'm going to talk about here are a lot of the common risks and complications of surgery, what to expect after the operation, what the operation's about. By no means is this comprehensive. It's just meant to be a general overview of some of the most important things a patient should know prior to getting the surgery done. Also, remember, the reason you're getting this procedure done is specific to your own circumstances. So your surgeon and you have already talked about the indications or reasons for getting this surgery done, and I'm not going to get into that part. I'm simply going to talk about the surgery and what to expect afterwards. TLIF stands for Transforaminal Lumbar Interbody Fusion. The T means it's through the foramen, it's transforaminal to get to the interbody area, which is the disc between the vertebral bodies, and it's in the lumbar spine. That's where the L comes from. After all this is done, screws and connecting rods are placed into the pedicles in the back of the spine to hold the entire thing together, and that's the fusion part. So basically it's a fusion of the low back between two bones to try to join them together so they no longer move. The surgery itself takes about 1.5 to 2.5 hours, depending on the patient's size and exactly what's being done in the operation. And there are some risks and complications that patients should know about. Bleeding and infection are common to pretty much all surgeries, so we'll start with those. Bleeding enough to need a blood transfusion is very rare in this surgery. The blood loss is typically about 300 cc's, which means most people won't even notice that they lost that amount of blood, and most people don't need a blood transfusion for that amount of blood loss. But during the surgery itself, the blood loss is typically pretty manageable. As far as infection is concerned, the risk of infection with any surgery is really related to the amount of surgery, the time of the operation. In general, with TLIF procedures, that percentage is anywhere from 5 to 15%. Most times it's just the skin that gets infected. It's a little red and irritated, and antibiotics take care of it. In some cases, it can be a very deep infection requiring multiple trips back to the operating room to remove the pus, sometimes even remove the hardware and wash everything out. And then it can mean multiple months of antibiotics to kill off whatever bacteria may have made it into the bones. It can be a very big deal. This is the reason why surgeries are done obviously in a sterile environment like an operating room. But in addition to that, we use antibiotics before, during, and after the surgery to try to minimize the risk of bacteria getting a hold somewhere in the patient's body. Also, we irrigate quite a bit during surgery, keep washing the area out to try to minimize the risk of bacteria getting a hold in the tissue and surviving after the surgery is done. In addition to bleeding and infection, another question I get asked quite a bit is, can I be paralyzed from this operation? There is no spinal cord in the low back. The spinal cord ends up around the L1 region, so the chance of spinal cord paralysis with a TLIF is pretty much zero. There is, however, a chance of nerve injury because in the low back, even though there is no spinal cord, there are nerves that run through it. Nerve tissue is very different than spinal cord tissue. Spinal cord tissue can get bruised and damaged and stops functioning pretty easily. Nerve tissue, however, is very resilient. Think of it like your funny bone nerve. You can bang it pretty hard and it doesn't get paralyzed. It hurts, but it eventually recovers. This is the same with the nerves in the low back. They are exactly that same type of tissue. They can be moved gently during surgery, and they usually don't have any long-term problems associated with them. Because of this, nerve injury is extremely rare from surgery. It's about on the order of 1 in 10,000 surgeries where there's some permanent weakness that was not present before the operation. Another risk during surgery that needs to be looked out for is a dural tear. The covering around the nerves is paper thin, and if there is a tear or opening that occurs during the surgery, it can cause spinal fluid to leak everywhere. By itself, this is no big deal. If that happens, the surgeon just puts some stitches in that opening and patches it up, and typically there's no long-term issue with it. It becomes a problem if it's not recognized during surgery and then after surgery continues to drain. It can cause problems with the bone healing together. It can even work its way out through the skin, and if that happens, patients can get meningitis, and that can be potentially very dangerous. In the end, as long as this is addressed right away, patients don't suffer any long-term problems. patients that get a dural tear have no problems recovering and have the same recovery process and same good results as people who don't have a dural tear, as long as it's repaired early. That by no means covers all the complications that can occur during surgery, but this covers the vast majority of the ones that occur in this type of an operation. There are other complications from the anesthesia itself. Obviously, patients who undergo anesthesia are at higher risk for heart attacks and strokes. It is a stress on the system, and patients who are older, frail, already have cardiac disease, are overweight, or who smoke or who have diabetes, they're all at higher risk for complications related to the anesthesia as well as related to the surgery. Once the surgery is done, patients are kept in the hospital for 2 to 4 days. First of all, the pain from this type of surgery is not the type that can just be taken care of by pills. We can't just send the patient home with some Percocet and expect them to be okay. The pain is fairly significant for most people, so it requires IV pain medication at least for the first day or two. After that, patients are transitioned over to pills, and then they're ready to go home. That is one milestone the patient has to clear before they can go home. Usually after surgery like this, drains are placed into the incision because after surgery, even though the surgeon does their best to make sure there's no bleeding when they're finished, once they stitch the skin up and the patient wakes up and starts moving around the next day, that area can start bleeding again. If it does, and if there's a lot of blood that collects there, it can result in a painful hematoma. To prevent that, most surgeons put drains in, which can allow the blood that starts to accumulate to get out of the body in the first day or two. Usually after about 2 days, the drainage tails off, the surgeon pulls them at the bedside, and that prevents a hematoma from happening. Patients usually don't go home with drains, so that's another milestone the patient has to pass before they can go home. In the immediate postoperative period, there's a risk of pneumonia. The patient has pain, which they do, and if they're on narcotics, which they are, most patients don't take deep enough breaths. Plus, they're not getting up and walking because of the pain, and that can all result in a pneumonia. Any inactivity can result in pneumonia. That's something that needs to be watched for in the immediate postoperative period. This is why we get patients up with physical therapy right away. We make sure they do their breathing exercises, all to try to prevent this complication. Another complication we have to watch out for after surgery is an infection. Although rare, an infection can present itself right away. Usually how it shows up is a patient starts having fevers, their pain in their back is getting worse and worse where the surgery was done instead of getting better and better day by day, and or they start draining. Drainage starts to come out. If that all happens, that's a pretty good sign that there might be an infection. In that case, the patient has to be taken back to the operating room. That fluid has to be washed out. The cultures are sent to the lab by the surgeon in the operating room. Once those cultures are sent to the lab figures out which bacteria they're most susceptible to, and the infectious disease doctors then place the patient on the appropriate antibiotic to try to kill that bacteria. Now, after surgery, patients are allowed to get up with physical therapy right away. Remember, we put screws and rods in the spine so the entire construct is stable enough that patients don't need to wear a brace, they don't need to be in a cast. They can get up and move with physical therapy right away. That is a huge advantage with modern implants. Once the patient gets up and starts moving around, that decreases the risk of pneumonia. It also decreases the risk of one of the biggest worries that surgeons have after a surgery like this, and that is a deep venous thrombosis, or DVT. This is otherwise commonly known as a blood clot. Once it forms in the legs, it can break loose and head to the lungs, where it becomes a pulmonary embolus. A pulmonary embolus is very dangerous. This is why if a patient has sudden trouble breathing in the hospital after a surgery like this, we immediately have to rule it out and make sure that that's not part of the problem. So another reason why patients are kept in the hospital for a few days is to make sure they're moving and they're active enough that they don't develop blood clots. They're watched for blood clots while they're in the hospital. Sometimes it happens even after they go home, but that's in cases where patients don't walk and move around as much as they're supposed to. Activity and walking, getting up and sitting down and moving around is very important. The other way to prevent blood clots in the hospital is with sequential compression devices. SCDs massage the calves. Massaging the calves with an SCD has been shown to decrease the risk of blood clots pretty dramatically. So patients who are in the hospital, while they're on bed rest, they have these compression sleeves on. The compression sleeves come off when they get up to move around. When they get back into bed, they're put on again. This is the best way to minimize blood clots in this type of surgery. Once the patient is ready to go home and they don't have any evidence of infection and everything went well and it's 2 to 4 days later and the patient's ready to be discharged, the last thing that remains to be seen is, does the patient need to go to rehab? If they can't move around, can't brush their teeth, change their clothes, bathe themselves, they really can't go home. Those patients need to go to rehab for a few days until they're strong enough to take care of themselves, and then they can go home. Some patients are able to go straight home. This is a decision that is not made before surgery because nobody knows how well the patient's going to be moving until after the surgery is done. So this is a decision made day by day after the surgery. The social worker, physical therapist, nurse, and the doctor all get together and try to figure out where the patient needs to go based on how well they're moving. So that decision, like I said, is made after the initial 2 to 4 days recovery period is done. Once the patient is home or in rehab and is discharged from the hospital, most surgeons will see the patient back for follow-up, get some x-rays, and start weaning them off their medication. Remember, these patients are on narcotics. They will need pain medication for anywhere from 4 to 8 weeks after the surgery. Obviously, we try to wean them down as much as possible and as fast as possible, but patients also need pain control so they're able to move. If they're not moving, again, they're at risk for pneumonia, blood clots, and other problems related to inactivity. Therapy usually is 2 to 3 months, and most patients from 3 to 6 months after the surgery are feeling pretty good and are usually ready to be discharged from care. Sometimes patients have ongoing issues. They have lingering pain. They have lower or slower healing because they're diabetic or they're smoking. And those patients need to be watched a little bit longer. For the most part, however, 80% of the recovery occurs by 3 to 6 months. Recovery, however, can continue up to a year after surgery. So even though the patient is discharged and feeling okay, they may notice continual small improvements up to a year after surgery. For the most part, at a year after surgery, patients are going to be as good as they're going to be. One thing that should be noted, expectations are very important in a spinal fusion. If patients are looking to reduce their back pain, 70%, 80% reduction, that's a good reason to get the surgery done. If patients are expecting 100% relief of back pain, this type of surgery is not for them. Back pain, for whatever reason, cannot be completely relieved even after a perfect operation with absolutely no complications and a perfect result. Patients, however, who have leg pain as a result of pinched nerves that are treated with a TLIF, they have a 95% satisfaction rate, meaning if they have leg pain before surgery that's being caused by a particular problem at this level and it's treated properly, they are happy they got the surgery done. They would do it again because it was so effective in relieving their pain down their legs. The problem with fusion is the adjacent segment degeneration that can occur, meaning the level above or below has more stress because these bones were fused together. The extra mechanical stress causes these discs above and below, because of the surgery, to degenerate a little bit faster. 5, 10, 15, 20, 30 years down the road, it can become a problem requiring more treatment and sometimes even more surgery. That is something the patient needs to know ahead of time. Finally, one thing I do want to mention about spine surgery is minimally invasive surgery. Minimally invasive surgery is the technique of using smaller incisions with smaller muscle damage, smaller soft tissue injury to get the same procedure done as would be done with a larger, more open incision. What does this mean in the spine? A midline incision, which is the traditional way of doing a spinal fusion, results in severe muscle damage as a result of the approach itself. The muscle attachments to the spine have to be stripped off. What that means is the blood supply is damaged. Also, the nerves that supply those muscles get damaged in the process. Also, the blood loss is more, infection's higher, and the pain is more. The minimally invasive approach goes through the muscle. Now, this sounds counterintuitive, but when you go through a muscle, you can move the fibers aside to get to the spine itself. This results in less blood loss, less damage to the muscle, less pain, and less damage to the nerve supply, so the muscles are still firing and moving normally. This is pretty evident on MRIs of patients who have had minimally invasive surgery versus those who had open surgery. The open surgery patients had less muscle bulk and more muscle damage. The ones who had minimally invasive surgery had more normal looking muscle at 2, 5, 10 years out from the surgery. So it does make a difference and it does help. Another thing it helps with is the adjacent segment deterioration I was talking about earlier, where the next level goes bad. It also turns out the minimally invasive surgery preserves the levels above and below a little bit better. It doesn't get rid of the adjacent segment degeneration, but it is definitely less. Bottom line is, ask your surgeon to do the minimally invasive approach for your spinal fusion. If they won't, or they can't, there should be a very good reason why they can't. If it's simply that they just don't want to, or they're not used to it, then maybe get a second opinion. Do minimally invasive surgery when possible is definitely the better way to go. That's it for the TLIF or transforaminal lumbar interbody fusion. If you have any questions or comments, please leave them below. And remember to look for other videos. Thank you.